Good evening, everybody, and welcome. I want to welcome you to tonight's presentation. This is Tucson Medical Center and Pima County Health Department's presentation on long-haul COVID, signs, symptoms, and treatments. And we're very excited to have you here tonight. I'm going to wait a few minutes as we have people rolling in. We have more than 380 people that have registered for this talk tonight. So I want to let the people roll in. I see our people coming in, and I want to make sure that we're live on Facebook. It looks like we're live on Facebook. We're all doing good. As people are rolling in, I want to say thank you to our panel. I'll introduce them in just a few minutes. And I want to thank our viewing audience. I want to thank Tucson Medical Center, and I want to thank Pima County Health Department for partnering on this. This is another installment of Pima County Health Department's and Tucson Medical Center's partnership on these healthy town halls, where we come together and share resources to share information that keeps you and your family healthy. We started at the beginning of COVID talking about vaccines, and we've progressed through vaccines, and we've progressed through pregnancy and vaccines. And this is just another installment on that, where we're talking about long-haul COVID. My name's Tim Bentley. I'm the Marketing and Advertising and Wellness Manager here at the hospital, and I'm very excited to be joined by this panel. I want to do a couple of house cleaning items for you as you join us, as people are coming on. There's a couple of ways that you can participate. This is a discussion format. We're going to give you some high-level information. We're going to share some information that we know now, but it is very much a discussion and a question and answer participatory participation, audience participation, and we encourage you to answer. You're watching two ways tonight. If you're on the Zoom call, you can look down on the bottom of your screen and you can ask a question in the Q&A section. That allows us to see it and cue it and make sure that we answer your question. You can also ask a question in the chat, although the Q&A is going to be a little bit better because we have some people behind the scenes that might be able to answer your question in a timely manner. If you're watching us over here on Facebook, I can see you live over here on Facebook. We do have people that are monitoring that page. And if you have a question, you can type it in right to the comment section, and that'll get up to our panelists. Finally, we're live here tonight on Wednesday, April 20th. And if you're watching this after the fact, you might be watching us on Facebook or on YouTube. You can still participate. Type in the question in the comment section. It will get an alert, and we'll get it to one of our panel of experts so that they can answer those questions for you. So speaking of our panel, I would love to introduce them to you. I want to say good evening to Paula Mandel, who's an RN and a nurse. She's the Pima County Health Department Deputy Director. Hi, Paula. How are you? Thanks for joining us. I want to say hi to Dr. Mo Mortazavi, right? Did I say that correctly? Mortazavi, he's an MD. He is over at Spark Medicine, and he is a specialist in concussions and brain injury. And he's got some insightful looks at the way that long-haul COVID affects the brain. Good evening, Dr. Sean Elliott. How are you? Dr. Elliott is a pediatric infectious disease specialist at TMC1 and works with Pima County directly as well. And I want to say hi to my friend Emily Rich, who is a master of occupational therapy at TMC Outpatient Therapies, and she can talk to us, and she will talk to us and give us some information about treatment. So let's just jump right in, Paula. You and I were talking a little bit earlier via email, and long-haul COVID is a new thing. You know, we're just getting through COVID, and also we have this new designation and new symptoms that are going around. Tell us, what does long-haul COVID mean? What is the actual definition of long-haul COVID?
Oh, Tim, that's a really good question. You know, like most of everything that's occurred over the last 2 years, this is just something that we haven't experienced before, and we are still learning. This is something that is being identified, and right now there's not a current definition, or I would say a perfected definition. So right now the CDC is describing or referring to long-term COVID as post-COVID, and I'm going to read this, post-COVID conditions as a wide range of new, returning, and ongoing health problems for people. And they can experience these symptoms anywhere from 4 months to 4 to 6 weeks, or even longer after they've been infected by the virus. And you know, researchers, they're still trying to figure out, what does this mean? We're getting new information all the time. Some of the things that researchers and the studies are talking about is that there may be several different syndromes that we're seeing in these long COVID symptoms. So some people are calling it an intensive care syndrome. Some people are saying it's a post-viral fatigue syndrome. And then, people are definitely have been saying long-term COVID syndrome. And, some of the symptoms I think we're still learning more and more about the symptoms, and there's a wide range. And for each person, it's a little different. I think most people know and have heard about people who are continuing to have, let's say, short-term breathing issues or breathing issues. They're experiencing fatigue. They're experiencing, what they call COVID fog. So some mental dysfunction, headaches, problems with sleeping. There's always the one that I think we all recognized way back in the beginning in 2020, that loss of taste and smell. But people are experiencing other things like heart palpitations. They're experiencing changes in their blood pressures. I recently, about a month ago, tested positive for COVID, and I didn't think my symptoms were COVID. I actually was seeing fluctuations in my blood pressure. My blood pressure went extremely high. Went and saw the doctor, and they're, oh, while you're here, let's do a COVID test. And so I ended up testing positive for COVID, because of my history with high blood pressure, I actually was a good candidate for monoclonal antibodies. As soon as I got those monoclonal antibodies, saw a decrease in my blood pressure. It kind of stabilized, but every once in a while, I still kind of experience that fluctuation on high blood pressure. And I'm now starting to go, man, is that the stress that I'm experiencing, or am I experiencing a long-term COVID symptom? So I think there's still much to learn about this definition and what people are presenting with.
Thank you for that. I think if when they look at this time back in 100 years, they do the research on the Google searches that we did. I think everybody thinks they have long haul COVID of some sort. I think it's just, everything is a red flag. Dr. Mo, I know you're a specialist in concussions and brain injury, but I think you're seeing some effects that maybe COVID has on the brain that you would see in a concussion or some sort of traumatic brain injury. What are you seeing in your practice?
Yeah, that's right, Tim. So over at Spark, we're sports medicine and we have a concussion center. And basically, as the evidence started to come out in terms of what long COVID symptoms were looking like, and in particular, some of the most common symptoms were really captured underneath what we call functional neurologic deficits. So this concept of fatigue, which could be both mental or physical, which was very common, including a lot of exercise intolerance. And we were like, well, that sounds pretty familiar, because particularly our concussions that we call complex concussions, or concussions with persistent symptoms, some of which last months or years, and these are still all mild traumatic brain injuries, would have very similar sequelae where they would continue to suffer with cognitive, vestibular, ocular, or exercise intolerance. So we luckily had a platform to really be evaluating and treating these patients, because we, for years, have been treating brain injury. And although long COVID, we look at it as a brain insult that's got a different etiology. It's obviously not from trauma, but it appears that a lot of the, once you've ruled out, stroke and some of the more specific structural lesions, which most of the time we can, knock on wood, you're left with patients that have a lot of symptoms related to functional or neurologic deficits. That's going to be your mild cognitive impairment, your cognitive fatigue, your cognitive fog, your exercise intolerance. I used to, run 5Ks. Now I can barely, get up the stairs without, something's not right, even though my cardiologist, ruled everything out, right? So there's a lot of that with long COVID. And so that group, we were able to sort of start to talk to the community primary care doctors, who were sort of like, well, what do we do now? And we started to basically see a small subset that we could handle in our center, and have probably seen anywhere between over the last year, 20 to 50 patients with this condition, and they generally come to us anywhere between a month out to over a year out. Probably on average, we're seeing these patients more like 4 to 5 months out, where it's been clear that this is going on and on and on. And then basically in our center, we do cognitive testing. We have the capacity to do formal cognitive testing in a few different ways. Sometimes work with neuropsych to do more robust cognitive testing. And then we do monitored exertional testing. And these are all things we already were doing for brain injury. So it's nothing new. It's just for a different condition that's underlying the functional neurologic deficits these patients are presenting with. And, with concussion and persistent brain injury symptoms, we do a lot of vestibular ocular testing as well to look at oculomotor control, vision, balance. So we were able to just sort of do this for the long COVID patients. And even in that area, we've seen more than 50% of the patients we see in our clinic anyway, and we've submitted abstracts on this that we recently were presenting at a national conference, looking at majority, more than 50% of the long COVID patients do actually have vestibular ocular deficits that look very similar to the brain injury patients. So
Dr.
it's really
interesting. I'm curious, when you say that vestibular, what does that mean? How would that reflect in somebody's at a diagnosis? What does that mean?
So those are vision and balance problems.
Okay.
Right. So simply put, that's what it means. So going one layer deeper, these are folks that not only endorse dizziness and visual fatigue and frontal headache and blurred vision intermittently, but these are folks that when we test them and we evaluate their balance on a force plate, say, or looking at their oculomotor movements using an oculomotor tracker, which are all things we use for brain injury. So we have them. We see abnormalities. So it's a combination of the objective and the subjective of what the patient feels. So symptoms and signs sort of coming together. And so those are a lot of things we focus on. Obviously long COVID can hit 10, 11 different organ systems, and there can be a lot of other problems that are outside of our wheelhouse. But it just so turns out that the functional neurologic, the neural symptoms are very common, probably the most common symptoms these folks are struggling with if you look at the evidence. So that becomes, I think, an important area to work with patients. And then once you've done the evaluation, now you get into the treatments, which are mostly neurorehabilitative and lifestyle changes for cognitive impairment, for exercise intolerance, and then mood and psychiatric falls under neuro too. There's a ton of that as well. So really being able to sort of address all of that. And those are some of the things, obviously I'll get into in the May session, but that's basically, my quick 5-7 minutes, whatever it is on that. So.
Dr. Mo talks about this is a broad discussion tonight about long haul COVID. For those of you that are watching, we do have 2 sessions coming up at the core in May. Dr. Mo will have one, and Emily Rich will have one as well. And we'll put that in the chat for you, and you can register for those. It'll be also online again, and also in person. There's a few spots left. Dr. Mo, I'll get back to you. Thank you for that insight. Dr. Elliott,
Pleasure.
How do I know if I have long haul COVID? I mean, all these things, it sounds like, I have them. If I Google them, I have them. It's Dr. Google says that I have these things. As a prevention infectious disease specialist, how do I know? Is there a test for this?
Yeah, thanks, Tim, and thanks to my panelists for joining us. I think first and foremost, people who are online and others out there who have long COVID need to know they're not in the minority, that there are a whole bunch of people suffering from that. In fact, a study just released today looked at 50 different trials. 49% of COVID survivors, just the initial COVID itself, 49% are having symptoms 4 months out. That's almost half of COVID survivors are having what we're calling long COVID. So that I think is just, I wanted to get that statistic out there just to reassure people that indeed you're not alone in the suffering you're having. Also, I specialize in pediatrics. So I see kids up to age 18 or sometimes 21 And adolescents and young adults are having this as well. Thankfully, not quite as frequently, but still 25% or so. So the patients that I'm seeing, just like we've heard Paula and Dr. Mo say, are coming to me basically saying, I cannot engage with life. You know, whether it's I'm spending time trying to cut through the fog, I'm spending time trying to get off the couch. Just all these things are just night and day different. So of course, it'd be fabulous to say there's a magical bullet to fix this, and we're going to talk more about that, but there is not at this point. It also would be fabulous to have a definitive diagnosis to say, oh yes, my test turned positive, I've got long COVID. And that is not true either. These are what we call clinical diagnoses. So interviewing the patient, examining the patient, and confirming what is their level of dysfunction. So Dr. Mo was talking about neurologic elements. Paula has talked about others. For me, it's pretty clear cut. Known history of COVID, followed by still having fatigue, still having potentially the changes in sense of smell, the changes in balance that Dr. Mo talked about, and especially what everyone's calling the fog. One of my teenage patients described it to me really well. Like he was trying to go to high school classes and could only last 1 or 2 periods before just collapsing in ultimate fatigue. And what he told me is, Dr. Elliott, I'm having a hard time getting to the higher parts of my brain, which is very much a beautiful description of what we call higher level thinking. So yes, I can find my way to the bathroom, but if I can tell you what needs to happen when I get to the bathroom, that's like processing, that's higher level thought process. So these are clear clinical clues or cues. Is there a test? Well, not yet definitively. And I think that's the meat of the question you're asking. 5 years from now, we'll probably be really smart about what we should have been testing today. And there are panels of tests looking at what are called cytokines. Now, there's a medical term which I cannot imagine many people have heard of. Think of cytokines as chemical signals, kind of like a chemical text signal between your cell phone and somebody else's. But in this case, the signals are telling our immune system, the way we fight off infection, that, hey, I need you to amp up and get triggered and go attack that part of Dr. Elliott's body over there. Unfortunately, with long COVID, those cytokine signals are triggering our immune system to attack ourselves. So we call this autoimmune. It's something where our own immune system attacks parts of ourselves. Why are there effects in the brain? Because that immune system is knocking out, it's killing support cells in our brains, which are supposed to keep our nerves functioning properly. And if they don't work properly, then our brains don't process. It's kind of like putting our brain electrical signals through mud or cement as it's setting. So that's exactly what's causing what our patients are describing to us. So it should be at some point in the near future possible to test those specific cytokine levels, those chemical levels. But at this point, there's no commercially available panel with which to send that. Importantly, and I think we'll hear more about this from one of the panelists in the near future, at the University of Arizona Department of Immunology, they are doing incredible research looking at long COVID, or what the official name is, post-acute COVID syndrome, PACS survivors, to identify exactly that question you're asking. How do we detect it? What are the markers? And then more importantly, what do we do about it? And I think all those are very important. But at this point, you know, as Paula has said, we really don't know what we don't know. Despite a blindingly fast pace of science and discovery, we got a lot of work yet to do to serve our patients.
Well, thank you for your research and the insight. I know it's changing rapidly, and we will continue to have these discussions as we go forward. You know, so it sounds like to me that if they see Dr. Mo or Dr. Elliott and they're going to say, I don't know if you have long COVID, but you have some signs and symptoms, you're going to send them to Emily. And so when Emily is going to get a patient, what kind of patients are you seeing these days? People come to you with what sort of ailments, and then what are you doing to help them when they get to you as an occupational therapist?
Yeah, so I guess actually I should just even describe what occupational therapy is real quickly for people who don't know. Occupations are anything you do to occupy your time. So from the moment you wake up, being able to shower, cook, drive your car, go to work or school, all the way until you go to sleep at night. Those are all occupations. And so my role is to help people to be able to participate as fully as possible in daily life. So anything that's limiting your daily life, like what we're seeing in long COVID, which is definitely the fatigue, the cognitive or thinking challenges. Cognitive just means thinking, the shortness of breath, the exercise intolerance, the sleep issues, gastrointestinal, like just the list goes on in terms of this really encompasses almost every body system for a lot of people. So the reason why I'm seeing them as an OT is because of this idea of your whole life, right? And so COVID long haulers are experiencing this whole life impact, a lot of them not being able to return to work and the majority not being able to return to work full time. And so I specialize in a condition called POTS, or postural orthostatic tachycardia syndrome, which just means when people stand up or change positions, their heart increases dramatically. And we are seeing that in some percentage of long haulers. Other forms of autonomic dysfunction, autonomic nervous system, it's just the things that your body does automatically. So breathing, digestion, heart rate, temperature regulation, all of those kinds of things. And it just kind of gets a little funky. It goes awry to some degree. So we're seeing some autonomic impairments. And then also we're seeing a lot of fatigue, and it's presenting very similar to ME/CFS or myalgic encephalomyelitis, chronic fatigue syndrome, which is also really common in people with POTS. And these are just kind of the people that I see. So it kind of falls into the same realm. And in terms of treatment, it is fortunately or unfortunately, we are really treating symptoms at this point. And that's how we treat these other conditions. And so my role is really about participating fully in daily life. And so it's really hard for me to do treatment in 5 minutes. So we're doing a follow-up lecture to this in May that I hope you'll be able to attend, and I can go into a lot more depth. But broadly speaking, when we look at treatment for long COVID, in terms of the fatigue, I would say the number one best thing that we can do for fatigue is managing your energy expenditure throughout the day, using pacing strategies and conserving your energy with strategies to work smarter, not harder. And so that's what we do in OT, is looking to come up with, what are strategies that you can compensate or modify an activity so that you don't use as much energy. For example, showering. If you sit down to shower, you're going to save at least a quarter of the amount of energy. And so using a shower chair is a really effective strategy that then you can do more if you were to have more energy later in your day. So that's, one idea for fatigue. The exertion challenges, the shortness of breath, the activity intolerance, these athletes who are now suddenly not able to even get from the parking lot into my office. What we are saying as of now, and I feel like the caveat of anything can change any day with the amount of research that is being produced, is that, not pushing yourself extremely hard early on is what we would typically advise. So letting your body heal and going in sort of this low weight and slow process over time, and figuring out kind of what you can get used to, especially if you have ME/CFS or chronic fatigue syndrome symptoms, because there's this thing called post-exertional malaise that a lot of people get, where there's basically flu-like symptoms. It's this delayed and also prolonged experience of very severe fatigue, not just being tired, but feeling like there's bricks and weights holding you down. And so that is not a productive thing for the body. And so the idea of, of like pushing yourself so hard. That's not really what we're going for. It's not going to be easy. There's definitely not an easy method to do this, but working with a therapist, whether it's an occupational therapist, a physical therapist, or even a really skilled personal trainer who has experience with chronic fatigue syndrome, with autonomic dysfunction, that is going to be critical in terms of getting back to that activity level. If you are having symptoms of POTS, there's a whole host of interventions that I would talk to you about, and I'm going to share those later in May. But it's things like, increasing fluid and salt, and with the caveat that if you have myocarditis, or if your doctors told you that there's inflammation in your heart, increasing your salt is not necessarily going to be a good thing for you. And so all of these things really need to be specifically worked on an individual basis. But using things like compression garments, tight clothing on your legs, and even an abdominal binder can sometimes help with your energy levels and your cognitive functioning. If you're having temperature difficulties with regulating your temperature, especially with how the heat is already started here in Tucson, using cooling garments and strategies to really compensate so that you don't get into those flare states. Those aren't necessarily beneficial for you to sort of worsen your symptoms. That's a big picture overview of treatment.
Well, Emily, thank you. And I'll remind everybody that Emily and Dr. Mo have 2 separate talks in May. Some of our folks behind the scenes will put that in the chat for registration and things like that. You know what, I want to do a quick reset and we'll get right to the questions that people have been asking. You're watching long haul COVID signs, symptoms, and treatments, a partnership with Tucson Medical Center and Pima County Health Department. We're live on April 20th, and if you have a question, you can put it in the chat or in the Q&A. If you're watching afterwards, if you're watching it on YouTube or on Facebook as a recording, you can put a question into the comment and we'll get those too. Let's get right to the questions. The most common question we get that I have, we have 110 pre-submitted. Maybe Paula can tell us, when does my smell and taste come back?
Oh, that's a really good question. I don't think we have a definitive answer for that. Some people experience symptoms for a short period of time. Others may be experiencing this for longer periods of time. This is again one of those questions that we just don't have enough answers for yet.
Okay, so we don't know yet, but are there any tricks or tips that people are working on yet? Maybe that we know. I see Emily shaking her head. Is there something that maybe people can do to get their taste back? Dr. Mo, I have a question for you in just a second, but Emily, do you have an answer to the taste yet?
Yes, and it's not definitive and there's not a ton of research, right? But in the last sort of like decade, there's been new research really on addressing smell, what's called smell training. And so basically you can use essential oils. There's a very specific way to go about this. I don't want to tell you just go out and get some essential oils and start smelling them, but basically you want to put some essential oils into a container that's large enough that you can really there's a very specific way to do it. But you want to associate the smells with memories that you've had previously. And so you want to use, there's studies on smells like lemon, eucalyptus, clove, and rose. Okay. But what they're saying more and more now is use smells that you have very close association of memories with. So maybe coffee grounds or citrus, certain flowers, or even colognes that you might be really familiar with. And over time, it's a good thing if you have some sense of smell. That means that your nerve is still working, but just trying to increase the sensitivity.
Great. Maybe you can talk about that in your May talk. That would be great. Or maybe share some information with us and we can put that on our website. Dr. Mo, a second most popular question is this brain fog. People are just, Dr. Elliott talked about it, they're out of it. If they have brain fog, there's some questions. Do they need to see a neurologist? What's that process if they're having those symptoms? Is it a neurologist? Is it an exam? What's the process for them?
Yeah, I think it first starts with sort of breaking down, what the brain fog is. A lot of the other speakers sort of talked about specific details Dr. Elliott was talking about a student who said, after my second period, I basically just hit that wall of cognitive fatigue. We'll hear this a lot from adults who are working. I used to go 8-10 hours, no problem. Now after 2-3 hours, I'm toast. So you start to get into the sort of the details of, is it just cognitive proficiency that's a problem, or is it more when the fatigue sets in that you have a problem, or is it a combination? So I think a good history is where it all starts. Like I said, most of these patients are going to fall under functional neurologic deficits that, maybe some mild cognitive impairment, but it's not a stroke, it's not a seizure. I mean, you got to rule these things out. So neurology comes into play when you're worried about these things, or you need to rule them out. Once they've been ruled out, it really becomes more of assessing the cognitive impairment. And there are ways to do that with cognitive testing. There's computerized cognitive testing, multiple formats of that. There's neuropsychiatric testing. There's Evoke Potential, which is a EEG-based type of cognitive test. So putting together the history with some tests, making sure you've done an appropriate rule out, that there isn't something more serious going on. If every one of these patients could go through neurology for that rule out, that would be great. But the reality is, even though we'd love that, we end up seeing a lot of patients who haven't gotten into neurology yet because it's a 9-month wait. And if we don't see those red flags, we go ahead and, common things being common, start to assess the cognitive impairment that likely is going to fall under a functional neurologic deficit. And then, at that point, once you start to characterize what it is, then you can start to target the treatments. And a lot of the treatments will be working with folks like Emily, working with speech therapy, folks that are going to really be able to provide some form of cognitive therapy, allow them compensatory strategies and coping strategies, make sure that their lifestyle modifications for work or school are appropriate so they're not overwhelming themselves. You want to set patients up to be successful if they have limitations and deficits. So you need to sort of rearrange what their cognitive loads look like for their day. So that's a lot of what we do, try to put together cognitive action plans for folks. And then really on the neurorehabilitative side, work with folks in OT like Emily and speech that can really help build up that cognitive stamina. And like Dr. Elliott said, no magic bullet here. It takes time and it takes effort. And, we just, our goal is sort of move in that right direction.
Okay.
And I know a lot of the questions are how long, right? We get that all the time. And we get that with TBI as well, right? And there is no good answer because these are very case-by-case basis. So for one patient, depending on how bad their impairment is, it might be a couple of months. For another, it might be a couple of years. And there's just really a lot of variability there. There is no exact answer for how long, like I could give you about a bone fracture. I'm going to cast that fracture in 4 weeks, it'll be better, more or less. But with brain injury and what we're seeing with a lot of the functional deficits, neurologic deficits with long COVID, there isn't an exact answer. You sort of have to see what the recovery trajectory looks like, what the impairment looks like, what the recovery trajectory looks like with treatment, and then you start to get a sense.
Good. Thank you very much. I hear you say that sometimes it's hard to get in to see a specialist. Dr. Elliott, can my primary care physician help me triage a little bit and make sure that I'm getting to the right specialist, or maybe doing some of those things because it is such a long time for some of these folks?
Yeah, absolutely. I mean, certainly the first couple steps, I think, are, as Dr. Mo just said, taking a really good history. And sometimes there are some very easily accessible first diagnoses. Somebody who is living with diabetes, maybe let's get the glucose, the sugar control under control. I mean, things like that. So in fact, I would encourage anyone who has or may have long COVID to first see their primary care doc, just to go to that first evaluation, and then they can maybe smooth the ropes to get a referral into Emily, Dr. Mo, and others like them who are helping.
Great. One follow-up question to that. There's a lot of chat and questions about people that are vaccinated and maybe they get their third or fourth boost. Is that an effective preventative measure against long COVID?
Yeah, so that is a really interesting question. It does appear that individuals who are vaccinated, so 2 doses of the mRNA vaccine or 1 of the Johnson & Johnson, and then boosted, the first booster, we're going to leave aside that second booster question for the moment, have, of course, a lower risk of having severely symptomatic COVID. Of course, that's not 100%, and a lower risk of being hospitalized, et cetera. They have a lower risk also than developing long COVID. And so being fully vaccinated and boosted, while it's not 100% protective, it certainly lowers the risk very significantly. The interesting component, this sort of gets back to what I was talking about, how long COVID is a sign of our immune system gone crazy. Individuals who have had COVID are suffering from long COVID right now and are not yet fully vaccinated. There are some early studies that have shown that they benefit from getting their vaccines updated. So if they haven't had their second dose of Moderna or Pfizer, getting the second dose and then a booster. If they've not been boosted, getting the booster. And what that really does is sort of help redirect the immune system to go after the virus bad guys and leave alone our brains and our hearts and our lungs, et cetera.
Great. I do know that we have some people from Pima County on behind the scenes. Maybe we can post Pima County's webpage on where to get vaccines and information on vaccines. Paula, I want to ask you a lot of questions tonight about not only long COVID, but about pre-existing conditions. People are worried maybe they have heart disease or they have diabetes or they have an underlying condition which puts them at risk anyway. Does long haul COVID, have we seen that can adversely affect people with pre-existing conditions?
The research is still coming in, but what we do know, and part of what Dr. Elliott was alluding to, is that vaccination at this point is one of our best methods of prevention, whether it is for long COVID or if it's for flu or some other communicable disease. If you have a high-risk medical condition, if you have high blood pressure, if you have diabetes, if you have a chronic illness, maintaining your immunizations, keeping up to date on those vaccinations for both children and adults, and being vaccinated for COVID is one of the best things that we can do to prevent people who have high-risk medical conditions, whose immune systems are compromised for one reason or another. Being vaccinated is one of the best prevention measures that we have.
Tim, I wonder if I could jump in.
Yeah, please do, Dr. Please.
And thank you, Paula, for that. Absolutely 110% agree. A common sense explanation is most chronic illnesses that humans experience are associated either with our immune systems also, like, we're in a delicate balance of fighting off the outside world, germs, viruses, bacteria, and trying not to attack ourselves. But sometimes our immune systems get messed up and they forget that they should leave alone our inner tissues. And so long-term cardiac disease, lung disease, diabetes, all have an immune basis. And even if it's something unrelated to that, a chronic condition is always associated with pre-existing damage to our cells, to our tissue. So if that then is somebody who then gets COVID, the virus itself can circulate and paint every single one of our organ tissues in the entire body and trigger yet another immune response. So it's basically like my walls are crumbling, here comes the battering ram, boom, I've got no walls left. That's what COVID does to somebody who has a pre-existing condition. So it is critically essential that anybody with a chronic condition get themselves protected. It's the smart thing to do.
Great, we'll put up that information. I see some questions, and we'll get to some questions in the chat, but I want to make sure that we answer this question. There's a lot of questions that were submitted about mental health issues, about depression, and not so much just brain fog, but just a sense of malaise. And whoever maybe feels comfortable, Emily, is that you're seeing that maybe where folks are depressed, and we can't blame it on COVID. Well, we can, but I mean we can't blame it on the pandemic anymore. It's a diagnosis that people have because of their COVID diagnosis. Is that correct?
Yes, and I always like to make sure to point out that it's not a cause of that they're experiencing, because a lot of people with these kinds of symptoms have been told that it's all in their head or that it's because of their mental health issues. So yeah, we're definitely seeing anxiety and depression, especially in a lot of the long haulers. And I think that's only worsened or exacerbated by still living in a pandemic. The fear of, I know a lot of long haulers have a lot of fear of, what if I get it again? Am I going to get worse? I had this period of recovery, maybe I've recovered a little bit, and the world is going back to normal. People are taking their masks off and feeling like they're stuck, because of the fear. So I think that only makes it worse in terms of still living within this. But I think one of the big things to focus on is what can you control? There's so much without that you can't control, that's outside of your control. And so you can do your best in terms of, caring for your body in the ways that you know how. So, eating a nutritious diet, moving your body to the degree that you're able, getting sunlight, some of those like really basic healthy living things can help with resilience and having a support system around you. And so although, maybe you have anxiety now as a result, sort of the looking ahead, I think just what do we do about it now? Finding the right care team for you, bringing a support person with you at those physician or, medical provider appointments if you need to, if you're experiencing any, challenges with people questioning your symptoms yeah, just like building that support system, having things in place. And there's a lot of strategies that we can use for autonomic regulation of getting out of that fight or flight state, which is, I think, in part what's happening with the anxiety is the body's sort of hanging out more in that fight or flight nervous system state. And so there's treatment for that too.
Great, thank you. Dr. Mo, there's some questions about related to headaches, and some lady says that her daughter had MRI and CAT scans on her brain and didn't show any symptoms. Is that normal that they would be having symptoms and they may not show in a regular screening?
Yeah, and just real quick, I'm going to piggyback on Emily on the mood,
please do.
And then I will jump on that question. I just want to say, I think that's, the mood, anxiety, PTSD symptoms in the long COVID group is a very important thing for us, all of us providers, primary care, to really be screening for formally. Based on the literature, it's 50 to 90% of these patients will have some form of this. And those type of symptoms can really, aggravate the other symptoms and exaggerate the other symptoms too. That's not to say that someone who has mood and anxiety symptoms can't have bona fide exercise intolerance or cognitive impairment. But when the mood and anxiety symptoms become primary, and you can, again, screen these things and figure out, sort of what's your primary problem, then it's really important that that's being treated. Otherwise, you may be treating the other stuff and neglecting the psychiatric component and really sort of finding yourself in a hamster wheel. So just want to throw that out there. And I think that's just a really important area in this group to talk about. And then going to your question about headaches, and I think neuroimaging.
Imaging was the question, if it's not visibly apparent on a scan.
Yeah, so we would expect neuroimaging to be negative for most of these cases. Again, if you're doing a rule out, you're worried about a stroke, et cetera, that's going to be part of your rule out. And it's, if there was a stroke, you'd potentially see something. But in general, most of these are going to be functional neurologic deficits, which means that the structural imaging, whether it's a CT or MRI, will look totally normal. As we start to get into functional neuroimaging or DTI scans that can look a lot closer at white matter fiber tracts, et cetera, then it's a little bit of a different story. And I think the research is emerging there. Certainly in TBI, mild traumatic brain injury, we see deficits with those type of scans. But the conventional scans that are out there, CT, 1.5 Tesla MRI, they're going to look normal in this group. And that just means structurally everything's sound. but it, so things, the structure of things look normal, but how things are working or functioning is a different story. And the way to assess function is to do functional testing, right? So just because the structure of the brain looks normal doesn't mean that I've tested cognition. I need to do a functional test to test cognition, right? So those are the differences.
Great, thank you. Dr. Elliott, there was a question about clinicians and people on the front line, maybe in primary care. Are they being trained to recognize these conditions? Nurses, clinicians, specifically at TMC1, are they being trained? Have you seen that in the clinics there?
Well, I think, unfortunately, and Paula mentioned this at her opening comments, we're so early in the understanding of what long COVID truly is that there's not yet a cohesive curriculum, a teaching pattern with which to extend to our clinicians. That said, however, there has been a huge amount of information, education, research that our frontline clinicians are seeing on pretty much a daily basis. I've been able to have the opportunity to summarize all that research in a blog, which goes to healthcare providers through the entire Southern Arizona Hospital Association, including providers here in Pima County. So
great.
They're getting a summary of all those things, but there's unfortunately, no great educator other than true experience. And I expect, again, 5 years from now, everyone's going to be an incredible expert at diagnosing and I hope managing long COVID. Again, a shout out to University of Arizona and their long COVID study.
I was just going to say that. Why don't we, Paula and Dr. Elliott, there's so much we don't know and so many people here that want to help. In the chat I see is like, what can I do to help? Would this be helpful? There is a study at the U of A, and Paula and Dr. Elliott, let me just share the screen for everybody that's watching. Here's the study. Paula, you want to maybe get us started, and Dr. Elliott give us some particulars?
Yeah, we're really excited. The University of Arizona, the health sciences have reached out, and they are reaching out to find people who are willing to engage in this research effort to help us learn more about long COVID, find that definition, describe the symptoms, and how do we treat those symptoms. And this is the information. I know that we're going to be posting it along with this information, and we hope that people will consider being a participant in this study.
Great. Dr. Elliott, do you have a few more details for us?
She summarized everything. Thank you. Again,
okay.
Knowledge is power, and we can only get knowledge if everyone can sort of contribute their own experiences. So I'm two thumbs up for the study, and I hope people can enroll.
Great. Thank you. And I see that the link is put in the chat. Tara, thank you. And that we'll make that available and put that in our Facebook page, and we'll share this slide on our Facebook page and other platforms too. Pima County will as well. I wanted to let everybody know that we have received probably 57 questions, including the 100 that we had beforehand. We're not going to have an opportunity to answer all the questions, but that doesn't mean we're not going to answer them a little bit later. And I'll submit the questions in general to our panelists, and we will have some follow-up information on our Facebook page and our website, and perhaps Pima County's website, to answer those questions, because they're really need some deep answers and a couple of thoughtful answers. And I'm just worried we're not going to have time for everybody. But that doesn't mean I'm going to suggest that maybe we run a few minutes long tonight so we can see what's happening here in terms of some questions. Paula, quick question on Pima County. Does Pima County have any programs in place that you are thinking about implementing, or that you have started in terms of treating or getting ahead of these issues like you did for COVID a couple of years ago?
That's a really good question. We're having lots of conversations at this moment. We know that many of our constituents have been impacted by long COVID. We know that many of our employees have been impacted by long COVID. Prevention, of course, is what we do in public health, but it doesn't mean that we don't want to collaborate and partner with the healthcare system on how can we respond to this syndrome. And so we're just in the beginning stages. One of the best things that we are doing, or I should say one of the most important things that we're doing at this moment is, again, that prevention piece. We really want to make sure that people are being vaccinated. We want to make sure that people are getting tested. And if they test positive, that they are at risk, their medical provider encourages them to seek treatment for COVID, that, we're making sure that information is available on monoclonal antibodies and also on the other viral medications that people can take. So that's one of the pieces that we're doing. But, we have a clinical team and an epidemiology team that wants to continue to help pull information, pull data to provide a good picture for our community. And we also have clinical staff that are very passionate, while they prevention is our primary function. We have people who want to think about what can we do to help with the chronic part, because we can provide education and there are other possibilities that we could possibly do for that chronic piece.
Great, thank you. Dr. Elliott or Dr. Moe, there's a lot of questions in regards to chronic inflammation, chronic pain, joint pain. People are asking, is there medication or some sort of treatment over the counter prescription that can ease those pains? Maybe both of you can take a stab at it. But Dr. Elliott, why don't you let us know first, and then Dr. Moe, you can follow up.
Yeah, sure. I think, not surprisingly, the challenges with fatigue, the easy burnout of our muscles, et cetera, and so forth, do correlate or track strongly with joint complaints. It's not always true that it's an actual joint inflammation. So unlike patients living with rheumatoid arthritis or an infection of their joints, but instead, I would imagine it has a lot more to do with the deconditioning, which is occurring in these individuals. So simply, and I don't mean to minimize, but simply throwing a pain medication at a joint pain is not going to be a wise thing to do if that further weakens that person's motor structure. So, and I think I'm going to sort of defer to Dr. Moe on what exercises or strengthening programs in a cautious, careful, planned way would be effective. Of course, we don't want to live in pain either. And so the typical meds we use for people suffering with rheumatologic joint pain are going to be things like ibuprofen, sometimes aspirin in the controlled setting, but certainly nothing more powerful than that. Dr. Moe, share with us.
Yeah, I agree with Dr. Elliott 100%. I think at least the patients we're seeing in our clinic, it's really secondary to, we're not seeing joint effusions. We're not seeing anything that look like our typical sports medicine, musculoskeletal, chronic injuries, rheumatologic, et cetera. And so one of the probably most important interventions is going to be the kind of things that, Emily and PTs and OTs are doing, right? Really getting these folks evaluated for appropriate levels of exertion and really honing in on what that dose is. Because when folks have exercise intolerance, a lot of times they just don't want to do anything, right? So what and like Emily said, if you overdo it, then they're going to have problems too. So you really got to hone in on that sweet spot of where they're at, and everyone's going to be different. And then you really have to start a program that includes exertional rehabilitation or an active rehab protocol. It may be as simple as 10 minutes on a recumbent bike every day, but that will have not only an important impact on brain recovery, but obviously musculoskeletal on their bodies. And then also working with some level of strengthening and working through any kind of deconditioning, depending on how long they've been less active or inactive. Emily, maybe you can comment some more. I'm sure you've seen plenty of this in terms of specifically what are some of the things you may do with some of these patients.
Emily, quick question: are you seeing? I know you're seeing patients, and I'd love to hear a little bit more in depth what you're doing. Are any of them on medication when they come to you? On any medications?
Yeah, I mean,
for their symptoms that they come to you for.
Yeah. I mean, there's a lot of people are trying a lot of different things, I think. So it's just a mixed bag, I think, at this point. But one of the questions that I have about some of the joint pain is those people who are having joint pain early on in their course. And those folks, probably it's not related to deconditioning. And so in that scenario, I'm looking at more central, like neurologic or nervous system reasons for why they might be having pain. And so there's some sensitivity, some hypersensitivity that often happens with some of this nervous system changes. So if people are having sensitivity to lights or sensitivity to smells or sounds, they're getting more jumpy. Sometimes that correlates also with sensitivity to pain. And it's not at all that there's not a reason for their pain. It's not that it's, fake pain or they're making it up, but the nervous system changes the signal coming from the body, and it's sending an alarm bell to something that isn't actually in an acute or immediate danger to their body. So that's just another reason why people might have joint pain, but it would obviously be on an individual basis. In terms of strengthening, a very specific strengthening program. And one point to the exercise intolerance in general is that a lot of people do better exercising and strengthening from a reclined or a laying down or a seated position rather than an upright standing position. So things like a recumbent bike, swimming, a row machine, sometimes Pilates, laying down, sometimes yoga. Those can be some more approachable things that don't demand as much from the body, but can lead to improved activity tolerance and strengthening.
Great, thank you. Dr. Elliott, I have a quick question. There are some questions and there's maybe some confusion that vaccines can exacerbate long COVID symptoms. Do we see that in the research at all?
No, you're right. It is, I think, a common misperception, and certainly there are those individuals who are feeling that they've experienced symptoms from the vaccines. Even those have been disproven in all the population studies. But I guess a person's individual experience is a very strong motivating factor. But very deliberately speaking about long COVID itself, there are no vaccine repercussions or side effects that would trigger long COVID, and certainly nothing that would make it worse. In fact, quite the opposite. As I've shared, getting vaccines actually have helped a fair number of people lower their severity of symptoms and even the length of their symptoms with long COVID.
Great, thank you. Like I said, we're going to go at about 7:05, and I want to give everybody on the panel a last bit of a wrap up. A couple of questions. Does long COVID cause hair loss? Does anybody know the answer to that? Yes, it does. Emily says yes. So everybody's nodding yes. So to answer your question, sir, yes, it does do that. So to put a bow on everything, I want to say, first of all, thank you to our panel for being here. Your insight and your knowledge has just been so helpful. I was talking to Dr. Cullen and some of our colleagues at Pima County Health Department, and there will be a second webinar and probably a third and some one-off talks. Dr. Mo, you're speaking in May. Emily, you're speaking in May at the core. And maybe we can bump those up again in the chat for people to register. And we will seek out the Pima County's, the health department's expertise on some additional ones that have been raised today. Dr. Mo, if you could put a bow on it, if somebody thinks they have long COVID or they're unsure, what advice would you give them?
Well, I mean, I think even a panel like this and getting educated on what that really means to begin with, and whether you sort of meet some of the criteria. And if there's any suspicion that you do, I think you should start with your primary care doctor. We've really done a lot, including all the people in this panel and others, to try to get the front lines to be able to manage this better, because I think there has been a lot of, well, we don't really see any any kind of focal specific problem on your labs or your x-ray or your exam. So, and sort of being dismissive about it. But I think over the last couple of years, we've learned a lot about this. I think our primary care group here in Tucson, certainly I've given a couple of talks to different groups in town. And I think they've got a great approach. And I think one of the key things is really, again, diving into the history, because as clinicians, we're taught to sort of rule out the red flags, right? But this is a situation where most of the time, it's not going to be the stroke or the heart attack, but it's going to be these more subtle functional impairments in cognition or exercise or mood, and to be able to screen to that sort of deeper level and get to the root of what's going on. And we just, on the front lines, need to listen to our patients. If we listen long enough, the information will come. And at that point, then the primary care doctors will really know sort of where to direct these folks in terms of further workup and referrals. And I think we're in a community, and this is evidenced by what's happening right now, a community that takes this seriously and has put a lot of different folks put a lot of work into really advocating for folks that are suffering with this problem. So what I would say is, start with paying attention to things like this, and then, trust in your primary care doctor to be able to start the process if you're concerned, and sort of go from there.
Thank you. Emily, what's the way forward? What do you see? If your crystal ball, you've been working with these patients, what message do you have for us tonight?
I believe you. Your symptoms are real and they're valid. And I'm sorry if anyone's told you they're not, but there's more and more research coming out every day, and it's just going to get better. We're going to have more answers, more studies, more understanding of this. So just keep plugging away, keep working at it.
Great. I will remind everybody that there is the study that's coming up. I'll put it on your screen again. Somebody did ask if the links, we could leave them up on Zoom. When we end this talk, they'll go away, but we will send an email tomorrow to everybody that's registered on Zoom with the links. If you're watching on Facebook, we'll put those links in a comment on this event so that you can grab them later, but I just want to make sure that they see that. Dr. Elliott, what say you, my friend? What's the bumpy road look like to you?
Well, I almost feel like, we could just drop the mic after Emily. I mean, to those who are suffering from long COVID, number one, you're not alone. There's a ton of other individuals who are suffering as well. Number two, it's not in your head. Oh, dear heavens, it's not. Number three, the mental health issues, I think I wish to really emphasize. In pediatrics, we've seen a 30% increase in children, not just young adults, but children considering and attempting suicide, intentional and unintentional drug overdoses. This is another pandemic, folks, and people are hurting. Anyone with long COVID is hurting. So please don't hurt alone. Do seek the resources, do contact your primary care doc, do take comfort in the fact that research is ongoing, and every day we're getting smarter and better about how we can offer help and support. Final thing, and again, this is just based on my experiences with my teenage and young adult patients who have long COVID. Almost every single one of them are like your typical type A, student athlete. I want to do everything. I want to get back in the saddle immediately. Please know that this is a long, slow process of recovery, and it's not going to happen right away. And anything that we as healthcare providers can do to empower our patients to escalate slowly, gradually, with control, with guidance, and not, to avoid the immediate return to full school and full work, et cetera. We got to work together as a partnership. And I think that is one of the blessings we can enjoy in this one pandemic.
Right, and thank you for saying that it is a partnership with our panel here, Pima County Health Department, Tucson Medical Center, our partners in TMC Health and Benson and Wilcox, Northern Cochise. We're all working on this together to get you information. You can go to the Pima County website for information on health and wellness and mental health and wellness. You can go to the tmcaz.com and also get health and wellness information. TMC1 has a mental health care component. So Dr. Elliott, thank you for saying that. And then Paula, I'll end with you. What does the road look like ahead for Pima County? What do you see?
Oh, wow. As I alluded to before, prevention is what public health is, our biggest role. I'm very grateful for the discussion that we had tonight and our community partners that are out there, and knowing that while none of us have the answers, there's so many community partners that are working to help support these individuals. The other thing that I'm just going to kind of echo behind Dr. Elliott is the increase in the suicide and overdoses that we have seen in our young population. And I don't know that many people are aware, but the health department has been working very closely with the schools this year, providing a liaison a partnership and providing education, information, testing, and et cetera. But one of the things that we are also doing is for parents and children who have tested positive for COVID. We are encouraging them to reach out to us to allow our partnerships with community partners to help them engage in the systems. If they are needing mental health support, if they are needing support within the medical community, I think it's, as Dr. Elliott said, it's one of the epidemics that are, epidemics that we
Sure.
are now experiencing, and we want to get ahead of before it's gets much worse.
It sounds like there's another opportunity for us to gather again and talk specifically about that. So thank you all for referencing that. It's very important. Emily, I love what you say, and Dr. Elliott, what you echoed is, we hear you. This is a real condition and it's not in your head. And I'm also very proud that we're here for our patients. I'm so proud to work with, smart and insightful and intelligent people doing good work to take care of our community. So thank you all for being here, sharing your knowledge. If you're watching tonight on April 20th, just know that people that registered for the Zoom will send an email with some follow-up information, follow-up links, questions that maybe we missed, and some further details. If you're watching this at a later date, you can put a question in the comment on whatever platform you're watching, and we'll get back to that. Panel, thank you very much. Our viewers, thank you so much for participating and allowing us into your homes, on your computers, on your laptops tonight. So thank you. So again, my name is Tim Bentley. This is Tucson Medical Center's and Pima County Health Department's town hall on long haul COVID, signs, symptoms, and treatments. Thank you all. We'll see you at the next roundtable. Thanks. Have a good night, everybody. Bye.